Hey, good morning, everyone. Let me know if you can hear me okay. Morning, David. Perfect, Madeline. My internet went out just a few moments ago, so, or not my internet, like our whole power went out, so I'm hoping we're not going to run into any issues this morning. Maybe that was the one little hiccup. But we will adapt regardless. We'll have a game plan and say if, if the power goes out and I don't come back in like, I don't know, 10, 15 minutes, just assume I'm going to record something and I'm going to give you guys announcements, but let's hope everything kind of goes off without a hitch. We'll find out. All right, well, it's 8 o'clock. I'm going to go ahead and get started here. Okay. I was looking at the sticky board. Didn't see any question. Homepage says 8:30, so a few people might be late. It should not say 8:30. That's ridiculous. That would I'm not calling you a liar. I think you're probably correct. That would be ridiculous if I would put that on there. Because 8:30 should be for... Oh my goodness, I did put the wrong time on there. My bad. Why would I do that? That's for next week. Should be 8:30 because that's when we're having the quiz. Oh boy, I better edit that just so no one can... That's okay. It's the benefits of being recorded in real time. We can catch back up. Anyway, I'm surprised no one sent me any questions, but I have about half of you guys here, so they can catch up, hopefully. Yeah, so I apologize about that. That's on me. Anyway, so we were discussing medications that we can use, or the different mechanisms that we're going to be looking at for managing depression and anxiety. So let's get into the actual drugs that do that. And if this is not the right starting off point, just let me know. Hey, Jillian. So first off, we have our MAOIs. These are pretty much the oldest group of drugs that we had to treat anxiety and depression. That was not a great set of drugs, as we'll see with the side effects. Actually, interestingly enough, we found that the first drug we had, iproniazid, was an anti-tuberculosis drug. They found that when patients were taking this, they would actually have their moods improved. And so I said, well, that's pretty interesting. Maybe we could try this specifically for mood. And they found that it worked. And since then, we've had things like phenelzine, tranylcypromine, isocarboxazid, typically the most common ones you'd run into. And again, they all share the same mechanism. They're going to be inhibiting monoamine oxidase A and B. Note this is going to be an irreversible feature. So this is going to be important in terms of how long the drugs are working for. So that can include serotonin, norepinephrine, and dopamine. So all those catecholamines can be affected here. Also note they can affect exogenous monoamines, which are going to be precursors to our catecholamines like serotonin and norepi, and that can lead to a lot of food and drug interactions, as we'll see here in just a few moments. So the most common ones you'll see include phenelzine and tranylcypromine. Again, you won't find too many patients that are on these, but it's still important to be aware of them and the side effects and things like that. But and we already saw one of these, selegiline, which is a more reversible one that affects monoamine oxidase B specifically for Parkinson's. We already talked about that. And you'll see similar interactions here. Note here in terms of adverse effects, it's not great, right? So you're going to see things like weight gain, postural hypotension tends to be the most common thing, just because you're affecting norepinephrine and you can't really regulate your blood pressure as well as you used to, or normally would be able to. So that's a big deal, especially for older patients. They're standing up quickly and moving around. That could lead to falls and things. And you'll see sexual side effects are very common with the majority of these antidepressant medications, mainly because of the fact that, we don't know why the full mechanism is, but oftentimes it can lead to things like decreased libido anorgasmia, things like that. So that can put additional stress on the patient if that is something that they are interested in, and can be a frequent reason for them to stop taking it or to switch to other medications. We'll see some ways we can try to get around that if possible. And then hypertensive crises. These are typically going to be seen if you have a pretty significant. And again, we talked about the tyramine reactions and the foods to avoid with selegiline previously in Parkinson's. This is even more important here because these are affecting both varieties of monoamine oxidase. And you can see much bigger increases in, or much larger increases in blood pressure and things like that, and leading up into hypertensive crises where you can run into things like that, nausea, vomiting, stiff neck, like actual end organ damage that can happen here. It's led to CVAs and death and things like that. Yeah, no problem, Toronto. Like I said, I was having power problems this morning, so I'm hoping everything will be okay. The weather radar didn't look too bad, but that's okay. Anyway, and you'll see this is mainly just treated with antihypertensives. So you'd use things like beta blockers, calcium channel blockers, and things like that. But this would be a kind of medical emergency sort of situation. And the problem with these is that because they're irreversible, you can run into these issues for like up to 2 weeks after they've discontinued the drug, because it takes that long to generate new enzymes. So that's one of the big challenges you'll see. Even though they stopped it a week and a half ago, they can still run into these drug and food interactions, unfortunately. So we've talked about things you want to avoid. So things like aged cheeses and meats. I talked about those kind of bougie foods before. Things like red wines tend to be more problematic. MSG, fava beans, soy sauce, things like that tend to have a higher amount of tyramine, which can lead to those interactions. Those are things you'd want to typically avoid. And again, up to 2 weeks after they discontinued the medications, they should still continue to avoid these. Again, there's lots of things they can't eat. So, fresh meats and cheeses, white wine, things like that are typically okay. And so it would be a good education point. Not that you're going to use these meds often, but the interactions do come up occasionally. But more importantly, you'll find medications that can interact with it, including things like amphetamines, which includes all of your ADHD medications, along with the illicit substances. Certain asthma medications, like your beta agonist, can do this. Cocaine, pseudoephedrine, and then other antidepressants, anything that can enhance the activity of serotonin or norepinephrine, can definitely affect this. So because of all the drug interactions, because of the side effects, these were not great drugs, right? So since then, we've developed further classes that try to help mitigate some of these side effects. And so then we had the TCAs. Again, we're going to find are not going to be perfect. But these are going to be derived from the phenothiazines, which are a group of antipsychotics that we're going to look at in a little bit. And these primarily block the reuptake of serotonin and norepinephrine. So it'll increase those concentrations. And again, that we don't know the full mechanism, but it probably leads to something downstream of that that can help with the symptoms of depression and anxiety. And these are typically, they used to be used first line. These were kind of like the gold standard. But since the SSRIs have come out, which we'll get to next, they have been supplanted. But you'll still see these used for things like insomnia and pain conditions. For a long time, nurse practitioners and PAs could not write for controlled substances, at least in Florida. And so they had to find non-controlled substances to actually prescribe for things like sleep, because a lot of the sleep medications are controlled. And so things like TCAs were frequently used in order to sort of skirt around that. But we'll look at some of the other issues and get into from a side effect standpoint. Available agents in the TCA class include things like amoxapine, amitriptyline, clomipramine, desipramine, doxepin, imipramine, and then nortriptyline. So a little bit bigger group to memorize the list for here. And again, being able to recognize these TCAs is important, obviously for exam purposes, as you've taken my exams before, right? Good. I think we have almost everyone here, so that's fantastic. To me, latecomers. Again, I apologize about the schedule online. That should have been 8 o'clock. Surprised no one emailed me about it beforehand, but that was on me. But if you're behind, feel free to catch up, and I'm not gonna hold anything against you there. In terms of why the TCAs are not preferred nowadays, it has to do with the fact that it doesn't just block the reuptake of norepinephrine and serotonin, but it affects a lot of other receptors too. This leads to a lot of the side effects. So, for instance, here they're strong anticholinergic muscarinic receptor antagonists, and that leads to a lot of the kind of typical anticholinergic effects, which are always good to remember. And this mnemonic I like to use, I've probably gone over this with you before, but just to, kind of hammer it in, you can see things like Mad as a Hatter, which means you have mental status changes, including, sedation at normal doses, but even higher than that, you can see anxiety, hallucination, seizures in some cases. Blind as a bat, meaning that they'll develop mydriasis and impaired accommodation of the lens, so that way they can have blurry vision. They can be hot as a hair, they can see hyperthermia, dry as a bone. This is a really common thing you'll find with these, where they will have decreased mucus secretions, so they can have dry mouth. You'll have decreased peristalsis, so you can have constipation. You'll have urinary retention potentially. They'll be red as a beet, meaning they can have cutaneous vasodilation, you have some flushing, and then tachycardia. I was just on call the other night and had someone who had overdosed on a TCA, and tachycardia is like one of the most common things you're going to run into, is sinus tach with these patients. They can remain, tachycardia for days sometimes, especially after overdose. But the other big thing I worry about too with these drugs is their cardiac conduction delays, due to the fact they block sodium channels. So kind of similar to our class 1 antiarrhythmics, they can cause arrhythmia, and potentially that can be the downfall for the patient, unfortunately. They also can block alpha receptors. That leads to a lot of hypotension, which, maybe if they have a history of hypertension, that's not so bad, but certainly that can be can bottom out their pressure. Let's see, sexual dysfunction, weight gain, sedation. So a lot of side effects. These are not perfect drugs. And one of the other big challenges you're going to see with these is that, especially in overdose, these are like really, really dangerous drugs here. Like the monoamine oxidase inhibitors are pretty dangerous. These are extremely dangerous drugs. And in fact, some of my predecessors in toxicology, they talked about having just like beds set up in the ERs just for patients who overdose on TCAs, because it was so common. They were into that and they would get so sick. In some cases, succumbing within like 6 hours of an overdose. The issue is that when you give patients antidepressants, like say for instance you're depressed and you have thoughts of harming yourself, sometimes you're going to find those patients just don't have the energy to act on that. They'll just say like, oh, I'm better, the world's better off without me, but I don't feel like it. When you start someone on antidepressants, oftentimes they will, it takes weeks before they really get the full antidepressant effects of the drugs, but they get the energy back a little bit sooner than that, sometimes within a couple of days or weeks. So what you'll find is that they will have more energy to act on the thoughts that they're having, which can lead to those overdoses. So if the meds that you're giving them for their depression are extremely dangerous, that can be a bad combo. However, for a long time, this is like the gold standard. This is just the best drugs we had for depression, even though we knew there was a chance for suicidality in some of these patients. So that was kind of a double-edged sword that you ran into with that. However, nowadays, we have the SSRIs, which are now the gold standard, the drug of choice for most patients here. Because they're much more specific. They only affect the serotonin transporter. They don't affect alpha receptors. They're not anticholinergic. They don't block sodium channels in the heart. So, just to give you a comparison, if I have, say 2 patients coming into the ER as a toxicologist, and the reason why I talk about overdose so much here is because, again, these patients are depressed, and that is not super common, but is a risk. These patients trying to harm themselves, is that with an SSRI coming in, I may be concerned about the patient, but I'm not worried about them dying necessarily just from that, assuming that's the only thing they took. The TCA, I am very worried about them dying, and so you have to kind of set your concern level and how quickly you need to act and how emergent the situation is based off of what the substances they report being ingested. And so if I hear TCA, I'm extremely worried, just like I'm about something like aspirin, for instance, which I've talked about before. So again, the big benefit here, they're very specific for their receptors, and they're a lot safer in overdose. They have a better side effect profile too because of it being more specific. Main agents you're going to run into here include things like citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and then sertraline. So, Christina, not that the TCAs cause the suicidality, but it gives the patient energy to act on the suicidal thoughts that they had, or the thoughts of self-harm that they had there. So it sort of like gives them like a little bit of an energy boost to act on those negative thoughts there. So yeah, it sounds kind of odd, but there's this term we'll talk about more with the antipsychotic drugs called akathisia. It's kind of this term like, kind of like you have ants in your pants. Like you can't just sit still. Like you just feel uncomfortable in your own skin. You have this energy. You just want to just get up and just move around or run or something. It's a very kind of odd sensation if you haven't felt it yourself. But that's kind of the thing, they develop some akathisia, and they can then act on these thoughts of self-harm. And that's what you run into, especially when you see like adolescents and peds. And you'll see that as a black box warning for like almost every antidepressant that's out there, is that risk for suicidality, right? So it sounds like, again, it's counterintuitive. Like I'm giving someone a drug to prevent them from committing suicide, but it might cause that. Again, it's a short-term kind of thing, just until the drugs really kick in and take effect. But if you can give them a safer drug like an SSRI, that's going to be overall beneficial. Someone was asking, for a patient who OD'd on the TCA with tachycardia, how did you manage that beta blocker for a few days until tachycardia subsides? No, they're not going to die from the tachycardia. Basically, what you'll find is that the big issues I run into with those patients is, one, they get hypotensive. 2, they have a chance to seize, and then 3, they have a chance to go into ventricular arrhythmias, right? So if it's sinus tach, I don't really care about that so much. But I'm looking at the EKG, making sure they're not having any kind of like signs of sodium channel blockade, which is normally evidenced by the QRS lengthening. And then I'm also monitoring for seizures and giving meds to keep their blood pressure under control. If it's just sinus tach, I'm not really concerned about that. I'll just let it ride, not necessarily treat that. So it's a great question, but not necessarily. Not every single abnormality has to be treated specifically, and that's something you'll find as you get into practice and start to work with these patients potentially. I could do whole classes just on talk stuff, but I will not bore you with that today, even though I find it extremely interesting. A lot of people do, but that is not our purpose here. I'm going to figure out how to treat our patients for depression. So with the SSRIs, you're going to find a lot fewer side effects because they're really specific for their certain transporters there. And so what you'll find is they also have like less weight gain associated with them. However, a lot of the common stuff you'll see are going to be things like sexual disturbances, GI upset, and insomnia. So those are, again, common reasons why patients may not want to take the medication and may want to switch to something else potentially. They can also develop what they call kind of a discontinuation or withdrawal phenomenon, and this happens for patients that decide to abruptly discontinue their meds. And this can happen this can develop things like anxiety, sleep disturbances. They get really cranky and kind of anxious when they're coming off of it. And so ways that we can deal with that, because again, sometimes you'll find depressed patients are not consistent with taking their meds. They may decide to stop taking them if they don't feel like they're working, but the side effects are so bad they don't want to take them anymore. So you can run into this discontinuation phenomenon, and so we can deal with that. So if a patient wants to come off of the med, then we can build in a taper, so how they can try to taper off the medication over the course of a week or two, or by using drugs with longer half-lives or active metabolites. A good example of that is Prozac or fluoxetine. Has a good long half-life and some active metabolites. So that way the patient, if they stop taking it on Monday, it has a natural taper to where by Friday they probably still have some levels of the drug in their system, and that can help to ameliorate some of those withdrawal phenomena, which can be useful there. But you'll find some patients who are taking their SSRIs, they miss a day and they feel miserable and they want to get back on it immediately because of that withdrawal phenomenon. So it can be pretty, more disruptive for some patients than others. So again, for a lot of patients with anxiety, SSRIs will help in the long term. We'll talk about meds either for chronic treatment of anxiety or for acute. This is useful for the long term. However, for some patients, they'll find anxiety is worsened. So that's something to note there. And then notable here in terms of side effects is that you can have QT interval prolongation with citalopram and then escitalopram. Obviously, you can tell those two, escitalopram is the enantiomer of citalopram, so it makes sense that those have some similar overlap in terms of that particular toxicity. So again, if I had someone who would overdose on citalopram, again, any overdose, you're going to get an EKG on, but I would definitely be looking for QT prolongation with that one in particular, those two in particular. Oops. So as I mentioned, that black box warning for suicidality, again, this is going to apply to almost every single antidepressant here, so just assume this is like a class-wide effect. They tend to find this more so in like adolescents and young adults. But again, I think this could probably apply to older adults as well. And as I mentioned, that increased energy can be issues here. Or like if you have a patient with bipolar disorder, oftentimes by dealing with that depressive episode, you can uncover more of a manic episode, and that can lead to some of those self-harm sort of behaviors, which is obviously not ideal. But again, something you want to at least want to warn the patient about, warn their loved ones about, things like that. Next, we have the SNRIs, which are sort of the newer class of drugs we have for treating depression. These are going to be a little bit more similar to the TCAs in terms of their actions, meaning they block serotonin and norepinephrine transporters. So you're going to increase those levels in the synapse. However, they have a lot fewer side effects than TCAs because they do not interact with muscarinic receptors. You don't see interaction with the sodium channels and all of that good stuff. So these are much safer than TCAs and probably should be used before those. Because of its effects on norepinephrine, you also see it's good for neuropathic pain, kind of like we talked about in the ortho section previously, where you see it's going to be good for treating things like fibromyalgias and things like that. So that can be very beneficial from that standpoint. And again, if they have concomitant depression, then again, you can get kind of a 2-for-1 treatment there, which is good. In this class, we have things like venlafaxine, desvenlafaxine. So again, you can see the relationship between those two there. Duloxetine, milnacipran, and then levomilnacipran. Again, another case of a racemic mixture, and then getting the one enantiomer out there. So you'll probably find probably a little bit higher side effect profile with the SNRIs than just the plain SSRIs. So more things like GI disturbances and whatnot. Again, you're going to see sexual disturbances here. And again, this is probably not just venlafaxine. This is probably the most notable one out of this group here to do it, but really any of them can do it. But you can find increases in systolic blood pressure. That has to do with blocking reuptake of norepi and how that affects the alpha receptors on your blood vessels, which can lead to increases in blood pressure. So I'd watch out for that with really any of them, to be honest. And then duloxetine or Cymbalta. This one does have a little bit more in terms of anticholinergic actions. So you can see things like dry mouth and constipation, a little bit more similar to what you see like a TCA, for instance. Okay. Some other ones we have here include things like our mixed serotonergic agonist. And so we have things that can not only block reuptake of serotonin, but we also have means of antagonizing this 5-HT2 receptor. If you recall, serotonin receptors, there's like the biggest variety of those out there. And so this in particular can affect these 5-HT2 receptors. We have 3 in this group here with trazodone, nefazodone, and then vilazodone. Trazodone is probably the one I have the most experience of seeing being used. Nefazodone we don't use so much because of issues of liver failure and being caused, and so if you have a patient with like hepatic dysfunction, I would not want to use that at all. And then vilazodone is a little bit of a newer one that I don't have as much experience with, just because I don't see these patients all the time. I don't work in a behavioral health sort of setting routinely. Interestingly enough, with trazodone, this one, sedation is going to be a big side effect you're going to see with these particular drugs. And so, as I mentioned before, using TCAs for sleep as a non-controlled substance being used by like NPs and PAs, trazodone was another really big one. So I'd see a lot of advanced practice practitioners utilizing things like trazodone for sleep in patients who they could not write a controlled substance for. So you may see that occasionally. Nowadays, again, that's changed because of now that PAs and NPs can write for controlled substances. That may change, but again, a lot of people they it's difficult to treat old dog new tricks. They may be kind of stuck in with the habits that they've developed over many years. So probably stick with the same drugs. But one of the other big things you run into with trazodone is it does block alpha receptors. So this is a unique thing where it causes hypotension and dizziness. And notably as well, it can actually affect blood flow in the penis itself and lead to priapism. So I've seen several cases of trazodone overdose where a patient was presenting not because of side effects from the medication necessarily, maybe they're a little bit sleepy, but they actually came in for priapism, right? They said, I've got this erection, I don't know why it's here, I can't get rid of it. And that actually we ended up having to consult with our urology colleagues to come in and make sure it wasn't something we needed to do any sort of intervention on like draining or medication therapy or anything like that. Generally speaking, you can let the drug sort of wear off on its own. But again, that is, something from a urologic standpoint that could be really concerning. So anyway, so interesting mixed serotonergic agents, a little bit different flavor of action than you'll see with the other ones. And the next would be Bupropion. This is actually a drug we've covered before when we talked about pulmonology. This is known as Zyban when being used for nicotine addiction. And so again, this one works by blocking reuptake of norepi and then dopamine. So this one actually doesn't affect serotonin at all. It probably helps to kind of enhance release of that norepi and dopamine. And so this one is, again, can be used for depression, but also can be used for certain, substance use disorders. So I've seen it used for smoking cessation specifically. There's some combos you may find that have been used for things like binge eating disorders and for weight loss potentially. So you'll find maybe some other uses as time goes on. Because again, why do people become addicted to things like food or sex or gambling or drugs? It has to do with dopamine, right? You're having those dopamine, I call them the dopamine squirts. You know, if I eat a big juicy hamburger, it's like, that tastes really good. Or how about a pub sub? I love pub subs. I get a big dose of dopamine every time I have one of those. And so people crave that. They want to get back to that. They want to get more of that, especially for substances that they are particularly susceptible to. So it's thought that by helping to re-regulate that dopamine with something like bupropion, it helps to prevent that person from having as bad a cravings potentially. Is it true you can cause false positives for cocaine? I'm not familiar with that. We've talked about some drugs that can cause false positive for amphetamines. Let's see. Doing a little bit of live action Googling here. So when dealing with false positives, one of the things that's really important to consider is what assay you're dealing with. And so this is, it's funny, David, because I couldn't tell if you're referring to the cocaine or to the pub subs. I'm going to assume that you're referring to the pub subs. But one of the things you have to consider when dealing with false positives and negatives is you have to know what assay you're using. And so this is why it's important wherever you go work, get to know the lab people and ask them about their urine drug screens and get a list for things that are false positives and false negatives. So it could be for certain cases that you'll find that, certain drugs will become false positives, some will be false negatives. It just depends on there. So it looks like here, let's see, aid for smoking. Yeah, so this one, some false positive for amphetamine. So again, cocaine's usually pretty specific to cocaine and its metabolite. There's a metabolite called benzylecgonine. This is what you're actually testing for. But it makes sense. You can see bupropion having some cross-reactivity for amphetamine. So it looks like that is a risk, again, without reading this whole thing here. But again, a lot of that does depend on the assay that you're dealing with. So, on a case-by-case basis, but good thought. Anyway, because again, that's really important to know. And typically speaking, what you'll find is for like, say for instance, like you have a patient who's going for a job interview, and they say, "Oh, I'm taking this Wellbutrin. I'm really worried about. I read online that it could show as amphetamines. I'm really worried about doing this drug screen for this job. What can I do?" You can educate them and let them know that, hey, listen, if typically for jobs, if they do pop positive for one of those things, they then have to do confirmatory testing, right? So then they have to go through and do usually a gas chromatograph or a mass spectroscopy. They'll go through and figure out what the specific substance is, and if they determine it's bupropion, then you have no problems there, right? But again, it can be concerning if someone says, "Oh, well, you tested for amphetamines," and you're like, "Well, I've never touched amphetamines in my life." It's good to know that stuff kind of going into it beforehand and educate your patients effectively, because that can cause a lot of distress for sure, to be accused of something you have not done. So another big problem you'll run into, probably not a big problem, it's something that can be a big problem if it occurs, although it is relatively rare, is something called serotonin syndrome. And so kind of leading up to serotonin syndrome itself is what we determine to be called serotonergic toxicity. So symptoms of too much serotonin leading into something called serotonin syndrome. And so Madeline saying, thanks to pain specialist I was shadowing, said that it was cocaine. I had assumed it was usually amphetamines, but that were the most popular false positive. Yeah, that's my experience. Is typically amphetamines tend to be the most common things that cross-react. So I mean, any of your ADHD meds do, because those are amphetamines. Like pseudoephedrine is a huge player for that. So lots of things for amphetamines. Cocaine, my understanding is generally pretty specific. I've not run into too many issues with that. But again, could be assay dependent. So the one that they're dealing with may be more likely to. Who could say? Uh, anyway, so looking at this, the major things you're going to run into with serotonin syndrome, which again just have too much serotonin, is things like altered mental status. You can have hyperthermia, so again they get very hot. They'll have autonomic instability, meaning their blood pressure and heart rate are kind of all over the place, and then they can develop this increased muscle tone or clonus. You typically see this more so in the lower limbs, interestingly enough. And so you have someone that presents with hyperthermia, increased muscle tone, and altered mental status. You may be thinking of something like meningitis, for instance. And so you really have to go through and rule out all the other scary stuff that it could be before you sort of sit back and say, yeah, this is probably serotonin syndrome. But what most often is the culprit here is either you have someone on an MAOI that has consumed a food with a lot of tyramine, or some other drug interaction where, say, you had someone taking amphetamines plus monoamine oxidase inhibitor, or someone who's taking maybe SSRI plus something that blocks monoamine oxidase. And so I'll give you an example of this that I ran into personally. I guess not personally, I was the one that took the call on it at the time. But basically, we had a patient who, it was actually a surgery center that was calling us, which is not a common thing at the poison center. But basically, there was a patient who was having a parathyroidectomy. And so one of the things they'll do for that surgery is they will actually give the patient a dye called methylene blue. Methylene blue will preferentially be uptaken by the parathyroids, and so it visualizes it easier for the surgeon to remove. And so, unfortunately, what happened was that methylene blue actually acts sort of like a monoamine oxidase inhibitor. And the patient had been on SSRIs beforehand, and no one ever really screened them for that interaction. So in the middle of surgery, after the patient gets this methylene blue, all of a sudden the blood pressure starts to go up, their lower limbs start to get kind of stiff. And so basically, in the middle of surgery, having to deal with the serotonin syndrome, not a great position to be in for sure. So we end up having to kind of talk the anesthesiology people how to go through that and manage the blood pressure and the temperature and all of that. So it's pretty wild case. But again, it can happen when you least expect it in some cases there. And again, other problems you run into include things like hypotension. You can see seizures here, rhabdomyolysis from the increased muscle tone. So the biggest thing to do for these patients includes good hydration with IV fluids, typically like cooled IV fluids if possible. You can do things like evaporative cooling, where you can, spritz down the patient with water and put a fan on them. That can be a good way to do it. Ice packs on the axilla and the groin, for instance. And then actually, if you can give them something that blocks serotonin, that could be effective too. So something like cyproheptadine is an antihistamine, first generation antihistamine that we didn't go over too much beforehand, but it actually does block some serotonin, and that can be useful for this in some cases. Usually good supportive care is good though. So as I was talking about with these patients in non-compliance, this is unfortunately pretty common thing. And so again, if you expect them to go off of their meds, just due to talking to the patient, sometimes we get a feeling for if you think they're going to be compliant or not. Using something with a longer half-life helps to prevent those withdrawal phenomena. So that can be very useful from that case there. But the things that have longer durations of action, a longer tail on them, be careful adding on a new med, because you can sometimes cause sort of a dose stacking thing where you can find some toxicity. So for instance, like with the monoamine oxidase inhibitor, you gotta wait at least 2 weeks before you really consider adding on something new, right? Because again, you can get too much serotonergic activity if that is the case. Or if something like fluoxetine, maybe you wanna wait a few days before you initiate a new drug, because they're gonna have that fluoxetine sticking around for a while, okay? And you can see that too, just due to like kind of chronic tissue accumulation. So a lot of times what you'll see is it will end up having patients sort of start to titrate down off a dose of their old med, and then concomitantly increase their dose on the new med, so you get kind of a crossover thing there, where overall they have lessened withdrawal effects, but they don't have too much effect of any one drug at any one time. But it can be very patient specific and be a bit of an art more so than science. A lot of the TCAs are metabolized through CYP enzymes, so you definitely want to look for any interactions that are there. Again, I'm not going to get specifics into the details here, but just make sure you're looking it up. And then you can find some protein binding interactions as well with TCAs. Again, TCAs are kind of a problematic set of drugs anyway. I don't really like them in particular, since I've seen so many bad cases of them being used. But again, they're being used for neuropathic pain or something. They have their place for sure. And then most of the times, the biggest drug interactions you're going to run into are those dealing with serotonergic toxicity. Again, remember things like linazolid, right? We talked about that back, and then bugs and drugs section, that can block monoamine oxidase. That can lead to increased levels of those medications there, right? Or of serotonin. Methylene blue, as I talked about before. If your triptans, which we talked about for migraines, I think last week, they can also agonize serotonin receptors, just like your SSRIs are increasing levels of serotonin, right? So you can see how these can interact with one another through their activity at serotonin. And again, if you have the choice, you have the ability, you can have the patient, withdraw from their antidepressant over the course of, a couple weeks, have a washout period, and then you can start the new med. So in that surgery setting, if that parathyroidectomy was not an emergent case, which it did not sound like it was, you could have had the patient wean off of their antidepressant, just kind of, have them make sure that they're following up with other healthcare providers about that, make sure they're aware of things to look out for, and then have the surgery and then go back on their meds, right? So that could have been a thing they would have done had they screened that patient and caught that interaction beforehand. As I mentioned with QT prolonging agents here, this is mainly a problem you're going to see with escitalopram and citalopram, but this is going to be a big problem with other QT prolonging drugs, and this is going to be a lot of our antipsychotics, which we'll get into in just a little bit. And then, of course, sedating effects can be compounded with things like alcohol and benzodiazepines, which is, again, common things you'll find patients using while being depressed in some cases, right? So Christina says, what's a washout period? It's funny because I always use that term and I just assume, I guess everyone knows what I'm talking about, but that's a poor assumption on my part as a teacher. Washout period just basically means a period of time where you allow the body to sort of just wash out all of the drug from the system. So for instance, to that patient who needed that parathyroidectomy, if they had known about that interaction beforehand, they could have said, listen, okay, I want you to go ahead and titrate off your antidepressant over the course of like a week. And then we'll wait 1 to 2 weeks afterwards to get the body completely devoid of the drug, work it completely out of all the tissues it's been building up and all of that. And then once the drug's out of the system, it's washed out, then you can go ahead and initiate that new methylene blue, do the surgery, and then afterwards they can start their other med again. Okay, so that's what we refer to as we say a washout period. You'll see that a lot with things like clinical research. If they're doing like, different medications in the same person, they'll do what we call like a washout period where they'll give it, say 2 weeks between therapies to make sure the older drug is out of the system before you start a new one, basically. Now, also for depression, I don't get into dietary supplements too much, mainly because, either they're not really shown a ton of evidence to be like, yes, we really should consider this in the same league. There are prescription medications in some cases. Oftentimes, it could be kind of, some spurious associations with their efficacy. Not to say they could not be efficacious, but what you're going to find is, sorry, I have another test going on right now, so I'm trying to figure out what's going on. Anyway, so what we're going to see here is that St. John's wort, though, is actually can be used for depression. It does have some evidence for use here. So basically, this one actually has a compound in it called hypericin, which actually acts as a monoamine oxidase inhibitor with some activity there. So it also can help to block reuptake of things like serotonin and norepi. So we can use this for more mild to moderate cases of depression. And so the big thing you're running into, though, is that like patients need to know not to take this along with the medications that you are prescribing them for depression, right? Because you can run into that serotonergic toxicity. So if a patient wants to try this, they're more than welcome to, I would say, at least that's my opinion, because it could see some efficacy here. But make sure that they're going to talk to you about if they're going to be on another medication, they don't take this along with it. And unless you ask the question, hey, what dietary supplements do you take? Are you interested in something like St. John's wort? They may not be open to talking about or even thinking about mentioning it. So because of the interactions you can run into, this is why it's really important to try to suss out whether this is something they're taking or may want to take to make sure they don't mix and match these meds here, because dietary supplements can have huge impacts on your medications, right? So anyone that says that they don't work or they don't do anything, that's not true in a lot of cases. So other problems you're going to run into, though, especially of clinical importance, is the fact that this can be a CYP3A4 and a P-glycoprotein inducer, which means that it can lower levels of a lot of other medications. And so, for instance, if someone was on simvastatin for hyperlipidemia, this is going to lower the levels of that simvastatin, okay? By inducing that CYP3A4 and by increasing the activity of that efflux protein, that P-glycoprotein or PGP, it's going to kick it back out into the GI tract and you don't absorb it. So that's one thing you have to be concerned with because it could be on a lot of other medications that interact with it. Excuse me. And then serotonergic toxicity if it's mixed with other antidepressants. So that's a big thing to warn there. Generally speaking, with dietary supplements, because they're not under the purview of the FDA, it is recommended that if they're going to go this route, stick with the same brand product, and try to go with a more reputable brand, because that way you're more likely to get a consistent product from batch to batch, and that way what is on the label is more likely to actually be what's in that product there. So that's a big thing I always tell patients is just be consistent. Don't go and get like the bottom of the barrel stuff. Don't get stuff out of the back of a guy's trunk or something like that. Go with the reputable brand because you're more likely to get the actual product that's advertised, which can be a problem with some dietary supplements. What's on the label might not necessarily be what's in the product there. Anyway, so looking at this, generally speaking, start out with an SSRI and go on from there because that's the best side effect profile. I probably wouldn't use TCAs first or second line, mainly due to adverse effects. I don't think I mentioned it before with bupropion. The other big thing to note with that one, again, so this is specific for bupropion. I think I glossed over it, but if a patient's having sexual dysfunction due to like an SSRI, bupropion is less likely to have that. So out of the whole bunch here, the one that has the least amount of sexual side effects is going to be bupropion. So that can be a really good drug to use for those patients to try switching them to. But so like I said, start out with an SSRI. If the patient's like, man, I'm having a lot of stress with my partner because we're not able to, our sexual relationship has kind of gone in the tank because of, the drugs that I'm taking. Try something like Wellbutrin. That could be a really good option there. With TCAs, I probably would avoid that unless, they have like maybe concomitant neuropathic issues. And then I probably wouldn't use monoamine oxidase inhibitors unless it's really just kind of like last line sort of option you have for you. I feel like I missed a slide for bupropion. I apologize. Let me go back for just a second. Did I just totally skip over it? It's so strange. It wasn't hidden. So anyway, I just want to make sure I cover this. So another thing too to be really careful here is the seizures and arrhythmias. If you have a patient who has a history of seizure or arrhythmia, I'd be very cautious with bupropion because it can exacerbate that. I've seen some really nasty seizures, especially with overdose of bupropion. So that's another thing I would just be cautious with. And again, you're more likely to see like agitation and whatnot due to some of the noradrenaline effects there. But again, less sexual side effects. So this is why bupropion gets a lot of good use there. Anyway, so if a patient has treatment failure for any reason, again, assess it for their compliance. And again, this is a challenge because a lot of times you'll ask your patient, hey, are you taking the meds like you're supposed to? And they'll say, yep, definitely am. And it's like, well, sometimes it's hard to tell if they're lying to you or not because they don't want to get, the stern talking to, or they don't want to feel like they're disappointing their provider. So, again, be open and honest and be non-judgmental when asking them. And that they are compliant, then determine if they've had an adequate time period. Because again, it can take up to 6 weeks before you really see full effects from these drugs. 4 to 6 weeks to see full effects. So make sure they're getting adequate duration. They've tried it, and make sure that the dosing is appropriate for kind of where they're at. You can try switching around drugs within the same class if you want. So for instance, if someone failed sertraline, they could try fluoxetine, see how that works. So they could try citalopram. Different agents may work a little bit differently in terms of side effect profiles for them as well. Frequently, that's the reason why they stop or want to switch is due to the side effects. Not necessarily the drug isn't working. It's because they find the side effects intolerable. Then again, consider that washout period prior to starting a new agent. Again, with the shorter half-lives, you can kind of do that much more quickly than something like fluoxetine, which has a long half-life, as we mentioned. And then you may need to add additional therapy too, considering things like if they have concomitant bipolar disorder, which we'll talk about lithium in a moment, and then some of our atypical antipsychotics. You're starting to see this used more often where patients, you never want to use like 2 SSRIs together or an SSRI plus an SNRI because of the fact that they can have too much serotonergic toxicity. However, adding on something like an atypical antipsychotic is now being done more often nowadays, and we'll talk about those when we get to schizophrenia in just a little bit. But aripiprazole is a common one you'll see being used to add on for like treatment-resistant depression in some cases. Okay, so up next, let's move on to bipolar disorder. I don't see any questions on the sticky boards. I'm going to continue on here. So bipolar disorder, obviously this is where patients are going to be fluctuating between cases of depression and mania. And again, depending on how severe it is, the manic episodes may be more mild or can be more severe in some cases there. And so, again, you're going to find that for a lot of disorders like this, like bipolar disorder and schizophrenia, like medication management is really key and is, very much like kind of the cornerstone of therapy, in addition to things like, other psychiatric help, like, cognitive behavioral therapy and things like that. We don't really know why people develop bipolar disorder. Maybe it has something to do with certain neurotransmitters being affected here, maybe due to certain synapses being too hyperexcitable. Not really sure why that happens there. However, if a patient comes in and they're presenting manic, it's important to consider other things that could be causing that and rule out all the scary stuff. So, if someone comes in acting all of a sudden very manic and not really any obvious cause, like look for things like stroke or tumor. Look for things like endocrine disorders like hyperthyroidism, alcohol intoxication. Maybe they start taking hallucinogens, like maybe they were really excited about trying LSD. All of a sudden they're coming in because they're having a bad trip. Things like that. Once you can roll all that stuff out, then we can consider, this patient may have actual bipolar disorder. And so for these patients here, the biggest thing we want to do is make sure they can kind of get back to their baseline psychosocial functioning. You can find, especially for more severe manic cases, that it's difficult for them to maintain good relationships with their people in their life, keep jobs in some cases, keep housing. That you'll find there's a lot of concomitant substance abuse here, especially alcohol, stimulants, things like that. So our goal is to try to keep them at a normal level of functioning for them and try to prevent sort of these wide swings between mania and depression and try to keep them sort of at their baseline. So therapy is very individualized because it's so unique to each patient in terms of like the frequency and severity. And again, we'll get these patients in the ER frequently when they're coming in for a very severe manic episode where they may be a harm to themselves or others. And we need to manage that with certain medications, which we can talk about in a little bit. But basically, you're going to find patients generally need to be on some sort of mood stabilizer for their lifetime, for the most part. So this will include things like valproic acid, lithium, which we'll get into in just a little bit. And then we can find some medications that are useful for more acute symptoms, right? So again, you'll find medications for more the manic side of things. And then they also need to be on something for the depressive side, which is what we talked about, the SSRIs and SNRIs and things like that. So lithium was the first treatment we really had for mania, and interestingly enough, you used to be able to find this in 7-Up. It was a lithiated lemon soda. Thought it can kind of help out with your mood. Turns out that was probably not a good idea because lithium can be quite toxic, unfortunately. Question here. Said, for a patient failing an antidepressant, for instance, sertraline, would you want to up the dose and wait a few weeks before switching to a new drug? Also, would you want to switch to a new class or try another SSRI? Yes. Basically, what you're going to find is that you can go ahead and consider, okay, well, why is this not working for them? Is it because of a side effect issue, or is it because it's just not working for them? If it's a side effect issue, then I would say you switch to a different drug, okay? Because if I go up on the dose of that same drug, the side effects are going to get worse. If it's because it's not working, then you got to consider, are they compliant, or have I given them enough time for this to actually work? If you say, yes, they're compliant, yes, I've given enough time, then you can consider going up on the dose, right? If they start to get some benefit, but maybe not full benefit, maybe they're not as much benefit as you want to see, then go up on the dose. If it just doesn't seem like it's working at all for them, even though they've been compliant, you've given it 4 to 6 weeks, switch them over to probably a different drug. You can go within the same class, that's fine. Or you could go to a different class, but consider what their concomitant disease states are. Are they a smoker? Maybe bupropion might be a good option for them. Do they have neuropathic pain because of diabetes? Well, maybe an SNRI is good for them. Consider all those concomitant disease states, and that may lead you to choosing one class versus another. So that would be my answer to that. Again, it comes down to the perennial answer. It depends. There's a lot of options you can do there. And again, this is why behavioral health is such a challenging discipline. It's a very rewarding one, I think, if you get good at it, but it can be very challenging because your patients are all unique little snowflakes and they all react differently to these meds here, unfortunately. It'd be nice if everyone did the same thing and followed the textbook, but your patients didn't read the textbook before they came in, right? All right. So lithium We don't really know why it works. We just know that it tended to kind of stabilize these patients' moods here, kind of help prevent their manic episodes from getting more severe. And so the thing with lithium, it looks just like sodium to the body, right? If you look at the periodic table of element, which I'm not going to bust out here and bore you with, you'll find the two are very close to one another on the table. And your body can't really tell the difference between sodium and lithium, which is going to be important for some of the kinetics we're going to look at here. But from this standpoint, it's well absorbed. It's a small ion. It has no protein binding. It is not metabolized. It just gets peed right on out. And so with that caveat, you're going to say, okay, well, how is this going to be affected by sodium? You're going to find if the body is in a sodium retentive state, if it wants to hold on to sodium, it's going to hold on to lithium. If your body is in a state where it wants to get rid of sodium, it's going to get rid of lithium as well. Keep that in mind because that will be important for some of the drug interactions we're going to get into in just a little bit. I haven't never noticed this before. It's the slenderizing. I thought it was funny, maybe because of the diuretic effects you can get from this. But anyway, so again, for some people, this is still considered first line for mood stabilization. I'm starting to see a bit of a move away from this into some of the other meds, which we'll talk about here in a moment. But again, beware, efficacy may take several weeks for it to really kick in and can prevent things like manic episodes, reduce the suicide risk. Because again, think about these patients who are bipolar. Maybe when they're in their depressive moods, they really want to, commit suicide, but they can't act on it because they don't have the energy for it. Once they get into these manic episodes, that's where they can run into problems. Now they have all this energy to do so. And so these mood stabilizers can help to prevent that potentially. In order to, because lithium has such a narrow therapeutic window, that we have to do therapeutic drug monitoring for that. And so you can see here the levels we're shooting for. I'm not going to have you memorize the levels, but I'm just trying to illustrate here why we do levels, because of the narrow range between where it's going to be effective and then once we get too high where it's going to become toxic potentially. So you can see here very narrow range between 0.5 to 1.2 milliequivalents per liter. Notice how it's measured similar to how sodium is measured in the blood. So you also find that all right, we're there. Abrupt discontinuation may lead to relapse. Relapse and remission, I always get those mixed up. So you can see, basically they can fall back into a manic episode if they have abrupt discontinuation. And you're going to find this is a challenge with these patients because frequently when they're in a manic episode, like they feel really good. Like they don't think they have a problem, so why should they take medications for it? So non-compliance is a challenge. Consider if someone has a more of a hypomanic episode and they're like, wow, I got all this energy. I cleaned up my whole house. Everything looks good. Scrubbed all the toilets. Why do I need to take meds for this? Then, they can get into some of the more problematic behaviors, who knows, things like gambling or self-harm or things like that. And that's where, the issues lie. So that's why we need the medications here to prevent them from having some of those more negative behaviors. But you could combine lithium with other drugs, but it does increase the side effect profiles. That's one thing to be watchful for. And a lot of people do develop side effects here. So you will find that a lot of the adverse effects, some may be due to sort of peak dose effects. They happen kind of soon after you take a dose, about 1 to 2 hours or so. That includes a lot of things like GI distress and osmotic diarrhea, which perhaps that's why it's slenderizing, because you're having so much diarrhea associated with it. So I guess double-edged sword there. See some muscle weakness. And you're also going to find polydipsia and nocturia associated with this as well. So they'll have kind of a thirst response associated with the lithium, and then also a lot of nighttime needs to urinate, which may lead to bedwetting, incontinence in some cases there. So one thing to note. But the chronic effects are going to be more notable here, because patients may be on this for the rest of their life in some cases. And so fine hand tremor is a very common thing. About half of patients will develop this. This can be ameliorated by using things like beta blockers, by using longer acting formulations that can be helpful. And then they can also develop this nephrogenic diabetes insipidus, which is unique to lithium, where basically you can find that it causes the kidneys to be less responsive to antidiuretic hormone. So basically your body is trying to hold on to water and sodium, but the antidiuretic hormone is just not able to work on the kidneys, and so you end up having this very dilute urine. You can't hold on to that water, and it's going to be losing all of that into the urine there. Interestingly enough, the way we treat that is with loop or thiazide diuretics, which sounds kind of counterintuitive, but it has to do with sort of monkeying around a little bit with the sodium in the renal tubules and trying to cause other compensatory mechanisms to kick in order to treat that. So things like aldosterone release and the RAS system and all of that. So I'm not going to get too much into the details here, but just know that's how we end up treating that. It helps to kind of re-regulate the way we're holding on to fluid and salt in the kidneys there. But that's a unique thing with lithium, the nephrogenic diabetes insipidus. You can also develop nephrotoxicity, and interestingly enough, this can cause hypothyroidism because lithium can actually prevent the thyroid hormone synthesis. That's another thing you want to note. And again, what could hypothyroidism look like? Well, it looks like depression in a lot of cases. So you'd always have to ask yourself, well, could this be a thyroid issue, or is it true depression that we're seeing in this patient with bipolar disorder? Other things you can find are some cardiac anomalies, things like T-wave flattening, AV block. Find some skin manifestations, things like acne, psoriasis could be worsened by this, some weight gain and some mental status changes, some slurred speech, ataxia and whatnot. With overdose, this is another thing you can commonly find patients having had overdosed on if it was available to them. And you can run into either issues of acute or chronic overdose. An acute overdose would be something like, they take a whole bunch of it at one time because they want to harm themselves. Which can lead to its own issues for sure. But a lot of times it takes time for the lithium to kind of get across the blood-brain barrier to really cause all the seizures and problems that we run into with lithium. It's the chronic overdoses that are the issue here. And so when I say chronic, it basically means a sort of over a slow period of time. What typically happens is because lithium is completely renally eliminated, if you are in a state where you're not able to clear it from the kidneys, then you will slowly build up those levels, and that's where you can really build up high CNS levels that can lead to really difficult to treat seizures, and that's how the patients die. And so you got to watch renal function. You got to look at this over time to make sure you're readjusting their dose, to make sure their levels are not too high. So it's super, super important to look at the renal function. Otherwise, you can get in these chronic overdoses that it was really no fault of the patient. It was just happened to be their kidney function just took a dive, but led to this issue here, right? So again, anything that can lead to the body wanting to hold on to sodium is going to hold on to lithium. So that includes things like dehydration, vomiting, diarrhea, heart failure. All of that's going to lead to higher levels here. And then there's a lot of drug interactions to look at too. So for instance, anything that prevents the filtration of lithium at the glomerulus, including things like NSAIDs, ACE inhibitors, salt restriction, things like that, also lead to higher levels. And again, I've seen several cases of patients who are taking lithium normally for their bipolar disorder, and then all of a sudden they come in for altered mental status, and they find their levels are too high, even though they're taking their drug like they should, but it's because they started an NSAID for some, unrelated injury, and that led to too high levels there. So again, something to really, really be careful and warn your patients about, because you'd have to prescribe an ACE inhibitor for that problem to happen, but an NSAID, anyone could just take over the counter. Someone said, would TCAS and lithium be contraindicated since one increases energy for suicide ideations and the other reduces? Would they be a good pair? You could use the two together. I think more commonly you'd find lithium plus an SSRI, or any kind of mood stabilizer plus an SSRI, because of the better side effect profile. But for a long time before we had SSRIs, or before we had a lot of other mood stabilizers, I imagine it was probably pretty common for people to be on TCAs and lithium. And again, that increased suicidality, that's sort of an acute early phase problem, right? It's that first couple of weeks where the drug hasn't really kicked in for the antidepressant effects yet, but they have that increase in energy. Now, by giving them a mood stabilizer and giving them lithium, that probably helps to blunt that big increase in energy, so maybe they won't go and try to harm themselves. But again, it's hard to say because it is so individualized on the patient there. So yeah, I'm sure plenty of people have been on TCAs and lithium. And again, do I want a patient to overdose on both of those? Certainly not. That'd be a whole nother can of worms there for sure. But yeah, I'm sure plenty of people have been on that with some success. That's a good question. I'm glad you guys are thinking about this stuff clinically and how this might actually manifest and look in the real world. And again, no CYP interactions here, which is a benefit mainly because it just doesn't get metabolized, which is good. Okay, so next we're going to look at some anticonvulsants. Unfortunately, we've already been tested on our anticonvulsants. We already know a ton about these. These are the common ones. Again, you should still know a lot of the information about anticonvulsants from the neuro standpoint. I'm only going to ask about the ones that I mentioned here. But we started to see that by utilizing anticonvulsants, which makes sense, they help to decreased hyperexcitability of the neurons, that this could do the same thing for patients who are having manic episodes who are having a lot of hyperexcitable neurons, I guess. So they tried using it and they found that it actually do work pretty well. And you're starting to see these used probably more often than things like lithium, mainly due to better side effect profiles. So valproic acid, the very common one you're going to see out there. This is probably the most commonly prescribed mood stabilizer out there in the US. And so again, good for either for an acute manic episode or also for chronic therapy as well, which is nice. And again, we don't really know why it's useful for this. Maybe it's helping to mimic the effects of GABA. We don't really know. We just know that it works and helps to stabilize that mood. And I've seen this used for other things too. Things like, oppositional defiant disorder and other behavioral health stuff. Just if you just need to stabilize that patient's mood, valproic acid is pretty good. And again, be aware you can have some synergistic actions. You may find patients who are on something like VPA plus lithium. While they can have some synergy there, that does increase the risk for side effects. That's one thing that is notable. Remember the big things with valproic acids, hepatotoxicity, so really watch out for liver dysfunction beforehand. Certainly we know there's going to be some sedation associated with these, just like we saw for treatment for seizures. And the other big thing too is, remember, you do not want patients to become pregnant while taking VPA because of the neurotube defects you can see with that. And again, some of these manic patients may be, undertaking high-risk sexual activities and could become pregnant, right? So that's something you'd want to be certainly educating on and be watchful for. Maybe prescribing, contraceptives potentially, depending on the case there. Someone said, is nephrogenic diabetes similar to SIDH but in adults? They're actually the opposite problem. So with diabetes insipidus, it is either a case of your brain not releasing enough ADH or your kidneys not responding to the ADH. Whereas SIDH, you're causing, you have too much antidiuretic hormone. So what you'll run into is that with someone with nephrogenic diabetes insipidus, nephrogenic meaning it's happening at the kidneys, so lithium is causing your kidneys to not respond to ADH. You'll get that really dilute urine, you can develop dehydration, all of that. With SIDH, you typically develop what we call a euvolemic hyponatremia, where you're holding on to too much water and that dilutes out the sodium in your system, even though you're not hypervolemic. Kind of goes outside of our scope for today, but we can talk about that more when we get into the nephro section later on this semester. But yeah, so those are the opposite problems. So again, this is another one you're going to be doing monitoring for. So again, looking at LFTs for sure. And again, the therapeutic range is going to be listed here, but it can vary depending on the patient there. And again, don't memorize the number. I'll give you a number if I'm asking something about a level on the test. I'll give you the reference range. Next, we have carbamazepine or Tegretol. Again, this is kind of structurally similar to the TCAs, and why it works for mood stabilizing effects, we're not really sure, right? And I'm starting to see that this is probably not used first line, but may be useful for patients who have failed lithium or failed valproic acid. This could be a second line agent to use here. Someone said, with lithium, is sedation a common complaint, or patients feeling zombie-like, non-functional? Yeah, so I'd say those are kind of two different things. Like sedation mainly being sort of a depressed level of consciousness, which you can see. Probably not the most common thing you're going to run into with that, but you can see certainly with like a lot of our mood stabilizers, like valproic acid certainly can see. But that zombie-like thing is more so of like a almost like a flat affect kind of flattened mood sort of thing. That can be seen for sure. If you kind of think, and you can sometimes see this with patients on SSRIs as well, or antidepressants, is again, if you think about the normal fluctuations, this is how I visualize it in my mind. If you think about patients and a normal fluctuation in their mood, like you're not always at the same mood all the time, right? You kind of go through peaks and valleys, right? Probably when you are here for my lecture, you probably go into a really big valley, and then when you finish up and it's your Friday, you have a big peak afterwards. So I kind of think about these drugs as sort of cutting off those peaks and valleys and kind of bringing everything back to the middle, so to speak. So instead of being really depressed about stuff, maybe that valley only goes down a little bit from their baseline, right? So you have to equalize everything out. Similar on the upside, which is where you get to more of the manic symptoms, you kind of cut that off, that peak there, and get things back down to the middle. So some patients will describe that as feeling kind of zombie-like, just because you're kind of like in a big like, okay, whatever, I don't really care kind of mood, because you're not really able to have that vacillation between peaks and valleys. That's kind of odd, but if you talk to someone who's like been on these medications, that's kind of how they describe it too, is that sort of zombie-like effect where they're like, yeah, I don't really care, whatever, everything's fine, whatever, so they're kind of just kind of going through their day. Oftentimes that can be a sign of kind of over medication. So again, it's important to consider sort of that double-edged sword there between too much of a good thing can be too much, right? Christine's asking, would VPA and lithium be used prior to carbamazepine, or if you fail VPA, can you go straight to carbamazepine? It depends on the patient and what you're willing to do. I think some patients will go from, say, VPA to lithium, then to carbamazepine. Some people may just skip lithium altogether. Some people start with lithium. It depends on sort of what their pre-existing conditions are, what their concomitant disease states are, all of that. Because if a patient has a history of hepatic issues, I'm not going to use valproic acid. I might go lithium first. Patient has a history of renal failure, then maybe I want to go something like VPA first versus lithium, as an example. So those would be things to consider there. Probably carbamazepine would be kind of, if not VPA or lithium, then try carbamazepine if that's needed to be done there. Okay. Again, this is another one you're going to do therapeutic monitoring for. Note here, lethargy, ataxia, pretty common, like we've seen previously. And then recall, it can cause the SIDH. Not as severe as oxcarbazepine, but certainly you want to measure their sodium levels, make sure that that's not becoming hyponatremic. So again, if you had a patient who had a history of diabetes insipidus due to lithium, maybe try something like carbamazepine, and then you may have to worry about the opposite problem, right? So again, just be aware of kind of the swings there you can get in terms of various effects on the kidneys. It can become a little complicated, but you'll get a feel for it after a while. Also, it's going to run into a lot of drug interactions because it does induce CYP3A4, so be aware of that. And again, if patients are on oral contraception, all of a sudden you're metabolizing it more effectively, then that could lead to potential for pregnancy. So again, things you have to worry about. Oxcarbazepine has been used as well. The only big thing here is that it's probably better tolerated than carbamazepine. However, you're going to have more SIDH, so more likely to see hyponatremia, so definitely monitor for that specifically. Again, you can run into some CYP interactions here. But again, the sodium thing is a big thing I'd worry about as a change between carbamazepine to oxcarbazepine. And again, I'm kind of going over these quickly, mainly because we've covered them already, so you should already know something about how they work and whatnot from the neurology section. Hopefully, you did not dump all that info. Otherwise, I'd request you go and try to slowly pick it back up. Lamictal, I'm saying some people do like, mainly because of its less sedating effects you're going to see than some of the other meds here. So some people like that, but just be careful. Because again, you may be mixing mood stabilizers. You may be adding one onto the other. So just be careful if you use VPA and lamotrigine, because you have to drop your lamotrigine dose by about half, just to make sure you don't get too high levels there. And remember, the skin stuff is a big thing we worry about with Lamictal as well. Yeah, things like Stevens-Johnson syndrome being a biggest concern out of the bunch, right? Someone said, have you seen anticonvulsants used often with MAOIs? I'm a little confused on which drugs are best to combine, which ones should not combine, like SNRI and SSRI. So in general, stay away from the MAOIs if at all possible. SSRI should always be your go-to first line, unless they have like concomitant neuropathic pain, then maybe go with an SNRI. Okay. At that point, you can combine whatever mood stabilizer you want onto that. You're not really going to run into a ton of issues from that standpoint. But again, I'd probably avoid MAOIs just because of their bad side effect profile, just like I'd avoid TCAs for similar reasons, unless you really had to. So, but yeah, so again, think about what they need for their mood stabilizing therapy, and then also from their antidepressant therapy. And again, you can pretty much mix and match whatever you want, but go with an SSRI or SNRI. That's going to be your best bet 9 times out of 10. For the anticonvulsants, will we have all the same side effects, or will they be more tolerable due to different doses or being considered add-ons? Same side effects, right? You may find that they can have just the same side effects as you would if they're being used for anti-epileptic purposes. So the therapeutic ranges are identical between the two. So yeah, the same exact worries go into mood stabilizing effects as it does for the anti-epileptic effects as well. Yep. Okay, so those are the main ones. In addition to that, to the mood stabilizers, sometimes you need antipsychotics, which we're going to get into more detail in just a few moments here, but these are used for more acute issues of mania in a lot of cases. We'll see there's two main branches here of antipsychotics, first and second generation. The first generation drugs work primarily by blocking dopamine 2 receptors, and then the second generation drugs block dopamine along with these 5-HT2A receptors. So it'll be a little bit of a difference. I'll get more into the details on that in just a moment. But these can be useful for treating either as monotherapy or as in combination therapy with a mood stabilizer for acute mania. So if someone is, say, coming into your ER and they're being particularly aggressive, agitated, having acute psychosis, these are the drugs you want to use in order to get that patient under control in a lot of cases there. Again, these patients may be difficult to, if they are a danger to themselves or others, frequently are a danger to, especially hospital staff. Getting them under control can be a challenge. So sometimes we need chemical means of doing so. And this is where antipsychotics come into play here. Again, using these for long term, we probably don't know the full ramifications for that, but I'm going to get into the specifics of the antipsychotics here in just a little bit. But generally speaking, start off with a mood stabilizer. So we'll do something like lithium, valproic acid, probably as your two first go-tos. I'm probably seeing more VPA than anything else nowadays. Or in some cases, consider a second generation antipsychotic. That's a SGA. You can use if they're particularly aggressive. And then if they're having issues with anxiety, insomnia, we'll talk about anxiety later on, but benzodiazepine can be useful for that. And then something like oxcarbazepine, probably carbamazepine as well, can be more of an alternative agent. And then for severe episodes, you may need two drugs together. So I've seen cases of like Lamictal plus valproic acid being used together in order to help control some of those more manic patients there. And then if they're not having a good response, then you can always consider adding on a second generation antipsychotic at that point. So again, I may ask you on a test question, okay, the patient is already on this, not really being well controlled. What do you want to add on next? Okay. So, if they're already on, say, for instance, valproic acid, and I'm trying to think of another good example. Or maybe I'll say, okay, they're already on lithium, but they have a history of hepatic disease. What do you want to add on next? Like, valproic acid would not be a good thing if they had a hepatic disease, right? So, again, looking at the patient conditions to see which drugs they may be good candidates for. All right. So any questions on that section before I move on? And I don't want to get into the specifics of antipsychotics, so I'm going to talk about them right here. So moving forward, so we talked about depression, we talked about bipolar disorder, dealing with the manic episodes. Now I want to get into schizophrenia, which is going to be sort of a whole nother realm of behavioral health stuff because of its mechanism is so different here. But again, we don't have the full process here, but what we think is an issue with patients with schizophrenia is going to be an issue of dopamine receptor defects. Basically, what you're going to find is that different parts of the brain, you'll find these patients are going to have hyperactivity or hypoactivity of dopamine. I'll show you a picture where that can make more sense here in a little bit. And so based off this disruption of dopamine, whether it's too active or too inactive, that can lead to a lot of different symptoms of schizophrenia, which we're going to get in here in just a little bit. We'll also find serotonin is probably a little overactive, especially up in the frontal cortex. And we'll talk about how that affects dopamine here in just a second. But basically, patients with schizophrenia, they're sort of losing touch with reality, is how they describe it, where you're getting, basically, you can have like things like auditory hallucinations, you can develop these delusions, which are basically sort of like fixed false beliefs, like I'm the awesome teacher and you guys all really want to listen to me talk for 2 hours at a time. That's a delusion that I hold, and no medication can treat that. Or things like, ideas of influence, like, okay, the president's listening to me, I can get him to do this, X, Y, and Z, all kinds of different stuff they can come up with. Oftentimes you'll find their affect is either flat or it can be really inappropriate depending on the situation, or very labile in some cases. It may go from 0 to 100 in terms of mood very quickly there. And again, a lot of things like personal hygiene also suffer. So they have trouble keeping jobs or maintaining their relationships in their life and all of that. So a very challenging group of people here to deal with, because again, compliance is another big issue. Because if you have a voice in your head telling you that you don't need to take those meds, they're just hurting you, then they're not going to be compliant with that. So again, really big challenge with these patients here. So that also leads to a lot of relapses, a lot of hospitalization, maybe trouble with law enforcement, all kinds of issues you can run into from this. And they don't really learn from their mistakes. And so you see a lot of substance abuse. You see a lot of risky behaviors, like, high risk sexual behaviors, gambling, addiction, all kinds of stuff that can be, again, exacerbating all their other mental health stuff as well. So this is why this is a challenge to sort of get this under control. Not everyone's going to develop this stuff, but again, it's something you can see. We sort of break up the symptoms of schizophrenia into 3 categories with the positive effects. So these are things that are there that should not be there. We have the negative effects, which are things that should be there, which are not. They're absent in these patients. And then the cognitive effects that have sort of changed their ability to process things or to be able to, have some good executive function. So getting more specifically into that, with the positive effects, these are things like the auditory hallucinations. These are the paranoia that can come with this. These are things that should not be there but are present there, right? Normally, you should be hearing voices in your head, unless I guess it's my voice that you're hearing. But those are things that should not be there, okay? These are oftentimes the more dangerous things to run into because the patient has voices telling them to harm themselves or harm others. That's a problem, right? So that can be really the acute thing that gets them treatment, like in an ER, for instance, or dealing with law enforcement. The negative effects are going to be things that should be there, which are not, as I mentioned. So they can have a very flat affect. They can develop things like alogia, which I cannot come up with words for things, anhedonia, which I think would be like a cool like emo band name, but that's where you don't get like joy out of things anymore that you would normally find joyful. Avolition, you can't like act on things. You don't have any volition to do things. And so these are much less dangerous, right? Because these are preventing a patient from doing things. So, a patient's much less harmful if they're just sitting there not doing anything versus if they're, suspecting, someone's trying to harm them and they can react violently to that. So frequently, we're going to see, again, the positive symptoms much more dangerous in the short term. However, negative symptoms can be affecting a lot of their quality of life, as you'll see. And then the cognitive stuff includes things like impaired memory, attention, and may have sort of that labile activity or labile mood because of sort of impaired executive function. But they can't make good decisions for themselves in some cases. So our goal here is to try to get really aggressive therapy started early. Frequently, these patients are going to have this is a long-time issue they're going to be dealing with. So if we can try to get things under control before they start to have that psychosocial deterioration, that's going to be really beneficial for them. And again, you want to target certain symptoms. So if they're having more positive symptoms, deal with that first, and then you can deal with the negative and cognitive symptoms as well. And again, give them, it may take up to 3 months before you really see the full effects of the meds you're starting here. So obviously you want to avoid undesirable side effects, which may be a challenge, especially with some of the older drugs we have, and decrease hospitalization, make sure they can keep the best compliance possible. We'll talk about some means of doing that where a patient doesn't really have a choice, but to be compliant. There's some examples of that, and then hopefully minimize costs and reduce episodes. So the first generation antipsychotics we have, and this is the first things we had for a really long time, for decades. These are, and again, you can get a good feel for how these drugs work if you watch the movie A Beautiful Mind with Russell Crowe. A very interesting movie about a mathematician, I believe, who develops schizophrenia and sort of his struggles with that. But at one point, he goes on medications, and at the time, this is back, I'm not sure when the movie was set, I think in the 50s or 60s or something. But it was, these are the meds they had. Like, this is all they had to use for that. So you can see some of the downsides of those meds. But basically, with the first gen antipsychotics, these are blocking dopamine 2 receptors. Okay, so they block the effects of dopamine, and they primarily decrease the positive symptoms. So if you look in the nucleus accumbens, there's too much dopamine receptor activity. This blocks that. So those feelings of paranoia, the hallucinations, those are all mediated through this nucleus accumbens. This decreases that. Okay, so these are very good for positive symptoms. You're going to find they're not really good for anything else. They actually can worsen negative symptoms, and they can decrease the prefrontal cortex signaling. So it worsens cognitive and negative symptoms. But for the really dangerous stuff, this is really good for that. So you're also going to find there's a ton of side effects associated with these because basically you're sort of inducing like a Parkinson's-like state on these patients, which is pretty apparent when you look at the side effects here. So first off, if you block dopamine, you're going to see more prolactin levels. So this means you can see things like menstrual irregularities, gynecomastia, because you're having more prolactin, so you develop more of those effects there. So if you have someone who wants to get pregnant, for instance, may have troubles doing that because prolactin prevents you from getting pregnant because your body thinks it's trying to nurse a newborn, right? You're also going to find tremor at rest because just like we saw with Parkinson's patients, dopamine antagonism leads to that increase in acetylcholine, so you get that tremor at rest, just like we saw here, Parkinson's. And then the major limiting factor is what we call extrapyramidal side effects. These are the more direct sort of Parkinson's-like effects here, where you can develop basically this inability to initiate movement, where you can see things like the motor rigidity, the catatonia, due to blocking that dopamine, right? So again, this is sort of inducing a chemical state of Parkinson's by blocking dopamine 2 receptors in that caudate putamen, okay? To go along with that, you can also develop acute dystonias from these drugs here, and so we'll talk about which drugs are more or less likely to do that. But this includes a lot of like involuntary muscle contractions, and so you can see things like where they basically, especially of the upper muscles here in the face and the neck, they can get stuck basically. And so, I've seen cases where people get too big of a dose of something like haloperidol, and basically their tongue is sticking out, and their face is stuck in this grimace. They're just like that, and please don't take a screenshot of that and save it and distribute it anywhere, but they can basically get stuck in this case there, and they're just like, they can't do anything about it because all the dopamine is being blocked. I had one case where a newborn, I guess not newborn, they were an infant, they're still in the first year of life, about 10 months old. They'd actually gotten into their mother's first-gen antipsychotic, a drug called Navain, the brand name, and they actually developed something called opisthotonus. You can look up some pictures of that, but basically it's this like really severe back arching. Every muscle in that kid's back was extremely tight and contracted, and it caused extreme pain. And it was like, well, what's going on with this kid? They have meningitis. And it wasn't until we discovered what the mom's medication list was that we were able to identify what specifically was happening there. So again, it's not just of the face and the neck, but it could be other things as well, depending on the patient. So very severe. We'll talk about some ways we can treat that as well. We have some means of dealing with that. Other things you're going to run into include some akathisia. As I mentioned, it's that ants in the pants sort of feeling where they just want to get up and move around. They have too much energy, and they don't want to be stuck there and talking to you as a healthcare provider. It can be really challenging. So Christine was asking, are the EPS due to the dopamine attack? That's specifically what is causing that, yeah, for sure. So again, it's inducing that Parkinson's-like state is what we're seeing there. And again, if you look at the side effect or the effects of Parkinson's disease and EPS, the Venn diagram is almost just a single circle, right? They're very close to one another, especially very severe Parkinson's disease and very severe EPS look very similar to one another. Other things you can run into too are going to include something called tardive dyskinesia. Now, this is something seen with long-term first-generation antipsychotic use over the course of say years. This is something that is a potentially permanent effect and something that you don't want to have your patients have happen. However, this back in the day when this is all we had to use, this is sort of an unfortunate consequence that we just had to deal with. And this is basically, for years, if you're blocking all these dopamine receptors, the receptors become sort of hypersensitive. And so you end up kind of getting the opposite actions here. We can develop things like abnormal movements. The patient's having unintended movements all the time. So you can look up some pictures or you can look up videos. I would encourage you to Google this. Videos of tardive dyskinesia where they get this like chewing and licking movements. They just can't help it. They're just sticking their tongues out. They have these repetitive movements. And again, these are, it's not the same thing as dystonia. Dystonia is like an acute muscle contraction. This is sort of a repetitive movement issue. And so, again, not always reversible, unfortunately. So it's just an unfortunate sort of casualty in terms of that's all we had to use to treat schizophrenia for a long time. So we'll look at some ways we can deal with that as well in just a little bit. Additionally, you have a lot of other ancillary side effects with the first-gen antipsychotics, including alpha-1 antagonism, meaning you're going to see a lot of dizziness, postural hypotension, similar to what we saw with the TCAs. And they can also have antimuscarinic activity, just like that mnemonic we talked about before. Adds a hatter, dries a bone, all that good stuff. And so, interestingly enough, from the Parkinson's standpoint, you actually end up finding that drugs that have a more antimuscarinic activity actually block some of those Parkinson's-like effects. So they actually help out with the EPS versus drugs that are much more potent at just blocking dopamine and don't have a whole lot of antimuscarinic activity. And I'll show you a graph or a table that sort of illustrates that in just a little bit. However, these more antimuscarinic drugs actually end up worsening tardive dyskinesia, so kind of a double-edged sword from that standpoint. Good in the acute phase, maybe bad in the long phase. With the histamine blocking activity, you're going to see sedation and weight gain, and then certainly you can see some cardiac effects like sodium channel blockade, QT prolongation, all of that. So EKGs need to be monitored while patients are taking these. Especially if you have to start mixing and matching meds. You can imagine someone who's on antipsychotic plus something like citalopram. You can see, again, synergistic QT prolongation. You want to watch out for that. Most severely, you can find patients can develop something called neuroleptic malignant syndrome, or NMS. And this is kind of a similar in presentation to serotonin syndrome that we talked about earlier. But this is seen with the really high potency D2 blockers, and primarily haloperidol and fluphenazine. I'll show you the table of all the drugs here in a moment. But it can occur with any drug that blocks dopamine here. And basically what they develop are severe hyperthermia, altered mental status, they have hypertension, and then classically they talk about lead pipe rigidity. If you ever hear lead pipe rigidity, you want to think NMS is like a really classic way to describe it for like test questions and on the board and things like that. And it's really wild if you ever see it. It's like their muscles are just so contracted, which like the upper limbs get so contracted they just cannot relax at all. And that constant contraction can lead to rhabdomyolysis, renal failure due to all that myoglobin leaching from the muscles going into the kidneys. Not great, right? So, and we'll talk about the treatment for that here in just a moment. So here's a list of all the first-gen antipsychotics that we have here. The ones in green are the ones that I want you to know for testing purposes. Just know there are others that are out there, but you're not going to run into as commonly. These are just the ones that I think you're going to see on a more day-to-day sort of basis if you do see it. And things I want you to take away from this are not necessarily how many pluses are in each box, because that would be a very bad test question if I asked you that. But more primarily what I want you to focus on is going to be sort of the balance here between how potent it is at blocking dopamine versus how potent it is at all the other side effects that it has. Okay, so what I mean by that is look at something, say for instance like thyroidazine or Mellaril. Notice here it's not super potent at blocking D2 receptors, but it is really potent at causing antimuscarinic effects, anti-alpha-1 effects, antihistamine effects. So if you were to look at this, you would expect to see a lot of anticholinergic, hypotensive effects, a lot of sedation and weight gain associated with it, but you wouldn't expect a ton of EPS. You wouldn't expect a lot of acute dystonias, probably not a big risk for NMS to occur, okay? On the other hand, though, look at something what we call high-potency dopamine blockers. Fluphenazine and haloperidol. These are the two highest potency dopamine blockers we have. And what do you notice about these? Well, they really block dopamine too, so they're more likely to cause EPS and things like that. However, they don't really have a ton of antimuscarinic activity, not a ton of alpha-1, and not a ton of H1. So, if I were to ask you which ones are more likely to cause EPS, then you'd say, well, some more high-potency dopamine blockers, right? Which ones are more likely to worsen tardive dyskinesia? Those are going to be more of the low-potency ones that are more antimuscarinic, okay? So that's kind of the balance here I want you to get. If you had to ask which ones are more likely to cause constipation, was probably the more strong antimuscarinic agents, right? So that's kind of the balance I want you to kind of look between in terms of side effect profiles here, okay? If that doesn't make sense, let me know. Here's another good table. We'll talk about the atypicals probably next time, but looking at this, you can kind of see the relative likelihood of causing these different side effects here. Notice haloperidol and fluphenazine, very high likelihood of causing EPS versus a lot of these other ones, not so high, right? Things like chlorpromazine and thyroidazine, moderate to low, right? Versus anticholinergic effects much higher versus pretty low for the more the high potency agents here. Okay, so those are the things I kind of want you to get a feel for in terms of the different flavors of first-gen antipsychotics and kind of the side effects you'd expect to see. Okay, well, that makes sense. So the first-gen antipsychotics is very good at treating the positive symptoms. However, a lot of times the side effects lead to discontinuation. Okay, And again, you're choosing agents based off that symptomatology. Are they having a lot more, positive side effects? Are they having a lot of paranoia and hallucinations? Something like Haldol may be really good for that. Just know that you're going to get the downside of being more likely to cause dystonias and EPS and whatnot. Okay. So, in terms of treatment for the EPS, this includes dystonic reactions, includes akathisia. Treat it with anticholinergic. Okay. By giving an anticholinergic, you kind of help reset that balance there between acetylcholine and dopamine. We saw that disbalance in Parkinson's as well. But you can do things like diphenhydramine, trihexyphenidyl, and benztropine. So that 10-month-old that came in after taking their mom's antipsychotic that had that back arching, we gave Benadryl 2 IV, and that within a couple of minutes was able to relax those muscles. Okay, so anticholinergics, primarily antihistamines, which is usually where we see that, are going to be used here. So diphenhydramine, trihexyphenidyl, and benztropine are the most common ones. If that's still not working, you could also use benzodiazepines because they do have sort of muscle relaxing effects. For the tardive dyskinesia, I would avoid anticholinergic agents. Oftentimes, if you can discontinue treatment, that's good. But again, these patients still have schizophrenia, so it may not be good from that standpoint. So that's why they have what we call drug holidays. Now, you guys are good kids, not kids, you're good students, you're adults. But drug holidays is not what you do on spring break, or maybe what you've done in the past. It basically means it is a break from the drugs for a period of time. Maybe when their symptoms are relatively low, say taking a couple months off, right, and then reinitiating. It helps to limit the overall total burden of the body to the drugs and may hold off tardive dyskinesia for longer. Nowadays, though, the best thing to do is to switch to a second-generation drug. Okay, and that's going to be the general trend of things, is moving on to the second-gen drugs more often than not. For the NMS, the biggest thing is to discontinue the offending agent, obviously, and cool down the patient and hydrate them. And so, if anyone's familiar with a condition called malignant hyperthermia, this is something you may see in surgery or in the OR. I'm sorry, or the ER. This is something you can see sometimes with certain anesthetics. These are actually treated very similar, NMS and malignant hyperthermia, but so you cool the patient down, you give them cool IV fluids, ice packs in the groin, axilla, etc. And then you can actually give them a drug called dantrolene or Dantrium that is able to help act as a peripheral muscle relaxant. So by relaxing the muscles, it prevents the rhabdo from occurring while you're cooling down the patient, and all of that can be very useful. So that's kind of the true treatment for NMS is dantrolene there. And then if the issue is that we're blocking dopamine receptors, well, then let's give them something to activate dopamine receptors. And sometimes bromocriptine is used for this purpose here. So one thing to know with that. Here's a handy table that can kind of go through all of these side effects that talks about how to treat them specifically. And again, you'll probably get some questions about this on the exam just because these are kind of high yield sort of things I can ask about in terms of how to manage these different conditions, maybe which agents are more likely to cause them versus others that are not. Those would be things that we'd be looking for you to know for testing purposes. So I think I'm going to cut it there, mainly because I don't want to get into the second-gen drugs, so it's going to take me a while to get through all of that. So basically, looking at where we're at in terms of the course, next week, I believe we have a quiz scheduled. So I apologize about this week. The timing was off on there. But next week, we are going to have a quiz. And so basically, I'm going to do that quiz. It's going to be from where we left, or basically what we covered for neurology. So for the first test, we went up through epilepsy. So all the rest of the neurology stuff, up through what we covered today, is fair game for the quiz. Okay? All the information can be on there. And again, the quiz is designed to get you kind of thinking about things I think are important for the test. Kind of test question ideas I might come up with for the real deal. And so that'll be a similar 25 minutes you'll have available to that. Have roughly the same number and type of questions as the first quiz. And then we will meet here at 8:30 and then do the rest of our normal lecture there. And then wow, look at that. Next week, the following week, you'll have your spring break. So that's fun. Any questions about that so far? Or anything from the lecture today? And it will be through the same lockdown browser, so that'll all be the same there. So make sure you have your camera available and all that good stuff. What questions may I answer for you all? Can you repeat what the quiz covered? Yeah, so it's going to basically be from, I think Parkinson's was the next thing we talked about after the epilepsy. So Parkinson's up through what we covered today. So the first generation antipsychotics. If you have questions, feel free to send me an email or anything like that, and it should be good. I'm going to get your prescriptions graded this weekend. So you'll have that available, and I'm going to post up the next assignment actually today sometime, most likely. So you should have some feedback, and then can start working on the next one that will be due at your next test. So it'll be like 319, I think will be. So yeah, you got plenty of 1, 2, 3. Yeah, you have a whole 4 weeks before your next assignment's due, so it should be good. Yeah, so Christine's asking what it means to be an irreversible MAOI. So basically it means, so just like we talked about with like COX inhibition and aspirin and how like NSAIDs are reversible, but aspirin's irreversible. Basically means is that once an irreversible antagonist is bound to that enzyme, for the lifetime of that enzyme, it is inactive. It cannot do anything. And so in order for you to regain that effect of that enzyme, you have to generate a whole new enzyme, right? So that means that once you have something like, say, phenylzine on board and you've been on it for a couple of weeks, all of the MAOI that you have, for the most part, is occupied by that drug. Well, let's say that I stop taking that drug today. That means that all the enzyme that I have, even though the drug levels may be negligible, all the enzyme that I have, all that monoamine oxidase, is still being bound up by that drug until I'm able to generate whole new enzymes. And that can take up to 2 weeks to really see you to get back to baseline. So that's why the apparent half-life of the drug, the actual number of hours, is kind of misleading because the actual duration of action of the drug is much longer. It can up to that 2 weeks after discontinuation. So someone said, could you re-explain what EPS is? Yes, extrapyramidal side effects. These are the side effects that come about from blocking dopamine in the caudate putamen. So let me open up the neurology PowerPoint real quick here. Stuff mad. And again, this is all just extra stuff, so if you want to leave, you're allowed to. I just want to answer any questions people have. So if I go back to talking about Parkinson's, right, so if you imagine what this looks like here, this is the normal functioning for a patient without any kind of like dopamine antagonist on board. And again, you're able to have normal transmission here, so that way the thalamus can signal to the motor cortex to initiate movements here, basically, right? So if I block that, either through someone who is losing these dopaminergic neurons, like Parkinson's, or if I am blocking this directly with a medication, then you're going to find that this signal is being inhibited here, and I cannot transmit that signal over to the motor cortex. So it's more difficult to initiate movements. It can also lead to those acute dystonias where the muscles lock up, basically. And again, usually you see the facial muscles can be directly affected by this. I encourage you to Google some images or videos of acute dystonias, because it is, again, it can really drive it home in your mind when you see it, at least in video form. So basically, by blocking dopamine at these receptors here, especially the D2, you're going to get way too much inhibition on the thalamus unless the motor cortex is inhibited. You get that bradykinesia. You're not able to, you get that imbalance with acetylcholine, so you get the tremor associated with that, all that stuff that goes along with it. So that's the EPS that we're talking about, the extrapyramidal, because we're talking about the extrapyramidal tract here, side effects. If that does not make sense, let me know. Well, are there any other questions from you guys? Guys and gals, I should say. Well, if not, I hope, okay. Let's see. We learned to associate lead pipe rigidity with PD, with schizophrenia. PD-like symptoms only occur with treatment for schizophrenia. Yeah, so like with that lead pipe rigidity with Parkinson's disease, that's like a severe manifestation of a lack of dopamine. You are inducing that in these patients by giving them, especially a high potency D2 blocker. So if I give them haloperidol fluphenazine most commonly, they can develop that same lead pipe rigidity, and that's what can lead to that NMS that is seen with NMS. And it gets wild. I've had patients who have had not full-blown NMS, but they certainly had way too much antipsychotic action on board. And I was trying to move the patient's arm. It's kind of contracted up, kind of like this. And let's see my arms. But
I was trying to get the patient to relax their arm, and I was just like, just relax for me. And the guy was just like, he's getting really frustrated because he could not relax his arm to save his life, basically. And so we ended up having to give him some anticholinergics in order to help reverse that. Because again, it was like full NMS. If that was the case, we'd have to use dantrolene and cooling and whatnot. But we were able to give him some Benadryl IV, and that actually was allowing him to sort of reestablish normal activity of dopamine and allow him to relax those muscles there. So, yeah, it's pretty wild when you get to see that this stuff is all fascinating just because of sort of the myriad effects you can cause in someone by kind of messing around the neurotransmitters. So, stuff is just really wild when you get to see it in real life. All right. Well, I think that's it. So thank you guys and gals for joining me today. I appreciate it. So we'll have the quiz next week, and then we'll meet here 8:30. Again, I apologize about the mix up in schedule today, but it looks like most everyone joined us pretty quick. So, um, yeah. So does that cause? I mean, that's kind of what you're causing is these contractions to occur, and yet they can be reversed, especially with the anti-muscarinics. So cogentin, triaxiphenidil. Benadryl. We use Benadryl most commonly in the ER just because that's what's available to us. Yeah, that is certainly the way we help to manage that. Those are reversible. Versus like Parkinson's, which is sort of an irreversible thing because you lack that dopamine unless you can give them something like levodopa or something like that. So cool. Yes, thank you for asking questions. I really appreciate you guys being engaged and involved in all of that. It helps to keep things interesting for me, and so I don't just like drone on for 2 hours straight, even though I probably tend to do that anyway. But it helps, I think, give you guys more. You get more of the lecture too if you're able to ask questions and you can get some answers for that. So anyway, all right, thank you. I will see you all next week. Have a great weekend.